I am Hyoung Joon Joo from Korea University Annam Hospital, and thank you for having me in EBC 2021. My topic is repeat PCI for left main bifurcation ISR lesion. I have nothing to disclose. Current guidelines recommend both CABG and PCI for left main coronary artery disease depending on its anatomical consideration. PCI for left main coronary artery disease became feasible and safe as CABG. Therefore, the proportion of PCI for left main coronary artery disease is significantly increasing. The problem is that the PCI for left main coronary artery disease is associated with higher risk for restenosis and repeat revascularization. In Syntax trial, 5-year incidence for repeat revascularization after PCI for left main coronary artery disease was 26.7%. In pre-combat trial, ischemic-driven target-based revascularization was 11.4%. Importantly, as you can see the Syntax trial, there are patients underwent repeat revascularization after left main coronary artery disease PCI. I feel that some left main in-stent restenosis cases might be included in this population, and repeat PCI was a more common revascularization strategy for this population than CABG. Let me show one case. The case was a 47-year-old man. In 2007, PCI with endeavor stent was performed at proximal circumflex artery. 1 year later, in-stent restenosis was developed. We implanted another stent from left circumflex ostium. Final angiography showed good angiographic result. However, 2 years later, chest pain was redeveloped and coronary angiography shows severe ISR at LAD ostium and left circumflex ostium. So, we implanted 2 stents with final kissing balloon technique. Post-procedural IVUD showed good stent opposition. Only 1 stent stroke at the proximal edge of left main stent was insufficiently opposed, but we thought this result was quite optimal. However, 1 year later, severe in-stent restenosis was redeveloped at the LAD ostium. So we performed drug-coated angioplasty for that lesion. Final angiography showed good result. What we can learn from this case is that the lesions and the procedural involvement of left main bifurcation could be a significant predictor for in-stent restenosis. As you already know, the guidelines recommend drug-coated balloon angioplasty and repeat drug-eluting stent implantation for in-stent restenosis lesions as Class 1A. However, the clinical prognosis between drug-coated balloon angioplasty and repeat drug-eluting stent implantation, especially for left main bifurcation ISR lesion, is largely uncertain. We compare the clinical outcome between drug-coated balloon angioplasty and repeat drug-eluting stent implantation in patients with left main bifurcation ISR lesion. This is a single-center retrospective study and includes only 75 patients with left main bifurcation ISR lesion who underwent repeat PCI. Baseline characteristics show that drug-eluting stent group tend to have higher incidence of acute myocardial infarction presentation at index PCI than drug-coated balloon group. Previous PCI characteristics show that 33% had non-left main bifurcation lesion at the previous PCI. Drug-coated balloon group tend to have higher percentage of stent-in-stent cases and a little bit larger previous stent diameters compared to a drug-eluting stent group. True bifurcation rate was 27% in DES group and 29% in drug-coated balloon angioplasty group. At the time, before 2015, intravascular image was performed only at 35%. QCA data showed the post-procedural target lesion minimal lumen diameter was significantly smaller in drug-coated balloon angioplasty group. I feel that the selection bias on drug-coated balloon angioplasty favoring smallest diameter, and acute recoil after drug-coated balloon angioplasty might contribute this result. However, follow-up target lesion minimal lumen diameter showed only borderline significance. Difference of follow-up target lesion minimal lumen diameter was attenuated. Considering that the heterogeneous baseline clinical and angiographic characteristics between two groups, we performed the propensity score matching analysis to compare the clinical prognosis between two groups. MACE shows similar clinical outcome even after propensity score matching. Log-rank p-value in Kaplan-Meier curve was 0.64. Cox-proportional hazard models for MACE suggest that the true bifurcation lesion was the only one important risk factor for MACE in patients who underwent repeat PCI for left main bifurcation ISL lesion. In summary, 33% of patients with left main bifurcation ISL lesion had non-left main bifurcation lesions at the previous PCI. It suggests that the initial PCI strategy for proximal segment of main branch is very important. Patients in drug-coated balloon angioplasty group had a trend of less acute myocardial infarction presentation at index PCI and more stent-in-stent cases. And smaller post-PCI target lesion minimal lumen diameter was also noted in drug-coated balloon angioplasty group. This suggests that the non-urgent clinical situation and lesion complexities might make the operator conservative and suppress aggressive procedure. Finally, it might result in clinical outcome of repeat PCI for these patients. However, the incidence of MACE remained to be similar between two groups during the follow-up period. Multivariate Cox regression analysis demonstrated that the true bifurcation lesion is the only important independent risk predictor for MACE after procedure. So we have to consider CABG in these cases. Thank you for your listening.